Good afternoon, everyone. I am Tamara Smith. I am with Grifols, and we are sponsoring this talk this afternoon. You've probably heard a few times, but if you haven't had a chance to sign in, I have some pages up here if you wouldn't mind doing so. And I do want to introduce our speaker today. This is Mr. Brian White, who is a cardiovascular perfusionist at Wellstar Kennerstone Regional Medical Center in Atlanta, Georgia. He is a perfusionist, nurse. He can introduce himself as well, but thank you for joining us.
Perfusionist, nurse, blah, 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 a lot of other things as well. I do have a nursing background. I have done everything from anesthesia tech to orderly to nurse to data specialist to billing specialist to it's been a little bit of healthcare. I've been in healthcare one way or another since 2001, essentially since I was in my original undergrad. And it's finally led me to perfusion, which is wonderful. This is my calling. It's where I'm supposed to be. I'm at Wellstar Healthcare, Kennerstone Hospital, which is about 12 miles northwest of Atlanta, Georgia. Love it. I've been there for about 7.5 years now. Wonderful program. We do approximately 12 to 1,300 cases a year, mixed pretty much everything except for transplant. So what kind of leads me to this talk today is that a few years ago, as I think we all notice, we were having a lot of issues with heparin resistance. It comes and goes. It's not every single day. It's just sporadic. And that's exactly the way we were treating things, sporadically. We had no protocol. We had no standards. It was throw things against the wall to see if it works, treat when we have to, and then it's out of sight, out of mind. And I just didn't think that was something that sat well with me. So I dove a little deeper into it, and here we are. It's kind of become more of a passion pet project for me as well. And I think there's a more efficient way to treat these things. We'll talk a little bit about that. But today we will talk primarily about roles of AT3 anticoagulation, deficiency, thrombotic risks, and more than anything, I'm going to stay in the realm today because I will go to jail otherwise. Hereditary AT3 diagnosis is what we're going to talk about. If you guys have any questions that is outside of those, I'm happy to address them after the talk. But I don't want black helicopters over my house. So that's kind of where we're coming from here. This will be super interactive. So what I want to do is, and I've let them know as well, if you guys have questions during the talk, if you stand up and I see any of the mics, we'll address them right then. I think it's better to address them at the time when I'm talking about something, as opposed to you guys sitting on the question and thinking about it. And at the end, you're like, my legs are tired. I don't really want to get up. So then we just miss it. We don't even talk about the question. So the prevalence is always interesting in the population. Obviously, deficiency is not as rare as you might think. For those who work in open heart surgery, which is pretty much everybody in this room here, it's really no surprise. It's rare, honestly, in my opinion, to go more than a week or so without seeing at least one patient that has a level of deficiency in the form of resistance. It's either mild resistance or extreme resistance, where the surgeon's sitting there tapping their toes and saying, why aren't we on bypass yet? And you're just not there. You're given more and more, and then you're having to figure out what the treatment's going to be. And based on the ACT testing at your center and what you utilize, you may or may not have a clear picture of what the actual severity of the heparin resistance is. And let's not glaze over the fact that hereditary AT deficiency affects from 1 in 500 to 1 in 5,000, which is a pretty big range. There's a reasonable chance that someone here sitting in this audience has AT deficiency without knowing it. You may never know it if you never have a reason to have that level of utilization of heparin therapy in your life. You may go your entire life without worrying about that. And this is calling myself out with the level of nerddom I have, which I fully accept in my life now. I occasionally will go just for other purposes to any lab testing centers and stuff and get some panels drawn. I actually asked the lady at the front desk, do you guys send out AT3 levels? And she just stared at me blankly. I'm like, you know what? I'll back away slowly. Never mind. It's okay. Obviously, VTE patients are not exempt either, a little over 16,000 patients per year. So it's a significant issue that goes overlooked, I think. Let's not forget that this can affect women during pregnancy as well. We'll touch on that just a little bit, and the 6 weeks postpartum. Again, we'll touch on that a little bit because it can affect our jobs. So PEs and DVTs just happen, right? That's kind of, what we see here. PEs and DVTs just happen. That's what we've always heard. We have treatments for PEs, we have treatments for DVTs, we follow the guidelines, we give the injections, all the things that are supposed to happen, but there's nothing else that can be done. They sometimes just happen. We'll treat them as best we can. I think our perceptions on the current guidelines are missing something. I think it's something critical that could be a huge piece of the puzzle as well. And I think that all perfusionists can attest that heparin resistance is not all that uncommon. It's actually something we deal with on a regular basis. So we all know these essential roles, but I'm going to kind of glaze through it just to reiterate what's important here. We know the function as perfusionists. We know that AT3 plays an integral role, which virtually we would have no job without. So I think it stands to reason if AT3 is so immeasurably important in how we do our job, the response from heparin that we give 99.9% of, to all our bypass case patients. If that's the case, then why are we not looking into this further? Why is it such a nonchalant thing when we encounter this resistance? And again, I like to, it's in bold here, but I like to even say it. Never forget the fact that this anticoagulant activity is accelerated by 1,000 times when it's bound to heparin. So it completely stands to reason that if you are deficient on your AT3 level, it's going to bind, but it's not going to accelerate as well as you need it to. And then I'd like to touch on this because we'll talk about this in just a second. When these levels are deficient, these activated procoagulant proteins will circulate longer, increase the risk of thrombosis, and as we've all seen at some point in your case, you get that lovely little film, maybe on your reservoir, maybe on the depth filter, maybe somewhere else, and you think, well, we're close to the end of the procedure, maybe I can eke this one out, it's okay. My ACT number says it's fine, so it must be fine. I promise you, if you see that little film on your reservoir, it's also on your oxygenator, and if that doesn't, it's in there in the fibers, if it doesn't send tingles down your spine, you're not doing it right. So I like this slide. It just kind of gives you more of the feeling of how involved AT3 is specifically in the intrinsic pathway, contact activation rather, which is really more what we deal with in our profession. And more than anything, I think, it draws your attention to the involvement and what happens when you are deficient with AT3. I like this slide. It's a little more visual. This massive acceleration of AT affects heparin, but it's the entire purpose of why their partnership works so effectively. It's enter heparin, and the shape of this AT molecule is actually altered, thereby increasing this affinity for inhibition with factor 10 antithrombin. So I'm a visual learner. That's why I think this speaks to me a little bit more, showing the actual physical alteration of the shape here. So AT deficiency can be hereditary or acquired due to conditional aspects of what happens here, sepsis, trauma, that sort of thing. Again, I will stay in the realm of hereditary deficiency, black helicopters. And we all know if we simply continue to dose heparin to reach our number, that makes us feel comfortable. Then the after effects happen. They're out of sight, out of mind once they hit the unit. The thing is, once they hit the unit, these effects can be severe. And I know we do everything we can intraoperatively. Let's say this patient's resistant. We give another 5, give another 10, give another whatever you have to do to get that physical number that you need to go on bypass. You support them. You give the heparin you need during bypass. Give the whatever calculated dose of protamine you give. Everything looks wonderful. You send them out to the unit. That's it, right? That's our role. But maybe, just maybe, if we were a little more vocal about what's happening in the OR and about what we're seeing, hey guys, I had some significant resistance. I had to reverse it. Perhaps we should keep an eye on this patient outside because their clotting cascade, their profiles are off. Something's going on. Maybe we could prevent that emergency call where someone's coding with a massive PE on the floor. We have to cannulate via ECMO, and maybe they survive, maybe they don't. Been there, done that. I'm sure a lot of you guys have as well. So this correlation here, I like to kind of read it. I don't like reading slides word for word. I like talking to people, interacting, getting questions and stuff, but this stands to mention word for word here is hereditary AT3 increases thrombotic risk 20-fold. So that is more than factor V Leiden, protein C, protein S, any of the other deficiencies you see here, which likely you all have protocols for in your institutions, which is very reasonable. Do you have a protocol for hereditary AT3 deficiency? Anybody here? Anybody want to raise your hands? Do you have a protocol specifically for suspected AT3 deficiency? Nobody here. Maybe one. I will talk to you afterwards. That's kind of my advocation here. And there's a few components that help you create that. And I think it's completely worth it. It doesn't necessarily mean you need to use the product more. It doesn't mean that, this is a pitch to say you should use more just nonchalantly. It means you should use it properly and when it's necessary and in the right calculated dose. So even at mild deficiencies here, in the presence of VTE risk is elevated. My center does test AT preoperatively on patients. And I'll say anecdotally, at least, I am collecting data at this point. Even with mild deficiency detected, we still see some levels of heparin resistance. And this is this mild deficiency where maybe you're 70 to 80% AT3 activity. You still do see some mild resistance as well. I do use the HepCon. I think a lot of you probably do as well. There are probably also centers that still do standard ACT results as well. You know, it's difficult, but I think HepCon is revealing a lot of information as well based on the percentages, the HDR results that you get versus having an actual AT3 level preoperatively. And it tells you a lot about what you're going to expect for this patient. And I can tell you, again, anecdotally for now, it is very accurate, that AT3 percentage level, if you get a baseline at least. So this is interesting as well. We see age obviously plays a risk here with thrombotic risk. It's more specifically for those 15 above, but again, I like to call it back to that number that even, 70% by age 35. So if you're an adult perfusionist, that is 98% of your population at that point. Let's hope it stays that way. It is getting younger. I'm sure we've all seen that. And we're much more likely to see these patients, especially 15 above, in need of our services as well. So it's worth understanding that cumulative risk does increase with age. So diagnosis, we'll kind of skip over this a little bit. It doesn't have to be quite as specific. That's more in the hematology side of things. But to spare a genetics lesson here, ultimately this points out that each child of a person with an autosomal dominant disorder has 50% chance of inheriting this disease. So 50%. So it stands to reason why we see the volume of heparin resistance we do in surgery with the significant odds of passing these traits from generation to generation. So I like to kind of harp on this slide. This is my platform I stand up on. So plasma levels of AT3 are an excellent way to customize what we're going to need to support these patients on bypass, right? My center draws these levels. It's a wonderful number to have. It's an easy test. So if you're looking to maybe even try to talk someone into start testing AT3 levels, it's run on coag analyzers. It's simply a different reagent. It's a small investment for your centers. Your labs are able to run it 99% of the time easy. It takes, I think when we started running it, it was maybe an hour and some change. It's down to about 30 to 45 minutes now. We'll even run it on emergency patients sometimes when they hit the ER, and we'll have the results by the time they're up in our room. And how amazing would it be if you have an arch patient coming in that's somewhat stable, maybe not, and you get that AT3 number popping up and it's 45%. And you think, oh, shit, I can, replace this ahead of time. I can figure out what I need to do, have anesthesia, get this bolus of this drug. So I know that when we're ready to heparinize for this patient, which could be emergently, we have the right dose, we're going to have the right response, and we're going to get on bypass, as opposed to giving whatever dose you think you should. You check your first ACT on bypass and it's 310. Which, again, I think a lot of us has probably been there. And if that doesn't cause a pucker factor, it should, I don't know what will. And then you dose afterwards, and I won't go into all that. But so in this particular slide, our normal AT range, 80 to 120%. I think a lot of us have seen that. You've probably seen the calculator as well. There's a standard formula for replacing AT3. What I like to talk about here is, so reference plasma. I think we probably all heard, why do we need to necessarily give a drug, a purified form of a drug called thrombate, when we can give something like FFP? Reference plasma is about 1 unit of AT3 per cc of plasma, right? That's kind of, I guess most of us would refer to. It's a little more of an old school thought, but it's still valid. So I enter 3 things here: the quality, the volume, and the transfusion risk. So we all know transfusion risks come with any time you get a transfusion of any kind of blood. Then aside from that, does the patient need the physical volume of FFP if we're just giving it for an AT3 response? And then the third thing I say is quality. So the way that AT3 is actually collected and the way that plasma is collected is that people go to these donation centers out of the goodness of their heart, or because they make a little bit of money as well in donating. Plasma is collected from all over the country from all sorts of donors. Let's remember that genetics slide we just talked about, that 50% inheritance. So let's say somebody goes to these centers out of the goodness of their heart. They have 40% circulating volume and they have no idea that they are 40% AT3, but they're given their plasma. That quality's off. They do not test for those things in a unit of blood. They separate it out into plasma components, separate it further and further, so that unit of FFP you're getting that you thought was a unit of AT3 per cc of plasma is actually more like a half or less. So you're given that transfusion, you're given the volume, you're given everything you thought you were going to have, and it's way less of an effect. So what I basically want to get across here is that the efficiency of having a drug that you know the dose, you know the purpose, you know the quality and the purification process of it far outweighs the benefit or the drawbacks from giving that actual unit of plasma. I'll get off my box. So obviously an H&P is super important. There's some light bulb moments when you're reading those H&Ps, when you have these histories of VTE, excuse me, I'm getting over a little bit of a cough here. When you have those unexplained histories of VTE, DVTs, any sort of clotting history, that should be a light bulb moment of something might be off in this patient. We might have an issue. And if you couple that together with having an AT3, a pre-op baseline AT3 percentage, then you are armed to the teeth with information of what's going to come your way once you heparinize this patient to go on bypass. So obviously there are a lot of issues that can affect AT3 levels. I'll kind of skim over this because we are talking about hereditary indications here, but there are drug-induced deficiencies, there's consumptive issues, decreased synthesis, and also some issues, some situations where you can have increased AT excretion as well. And keep in mind, there are clinical considerations that affect how we view AT3 levels, deficiencies, types of deficiencies, but the takeaway more than anything is how they may affect the treatment that we provide these patients, and that's what I'm getting at today. So rationale for AT replacement here is, it's multifold here. I think surgically, in pregnancy, in medical patients, in hereditary deficiencies, I think that's kind of something I've harped on already. And we can kind of look at how it affects the person here more in a case study. Stephen here's 48. He does, again, that's the light bulb moment. He's got that history of recurrent DVT. He was diagnosed with a DVT in his left leg, now has symptoms of potentially maybe in the right leg as well. Family history with no signs of thrombophilia. So more than anything, it's the light bulb moment of we might be dealing with something going on here. And the takeaway, again, I like this, is 70% of patients with hereditary AT3 will have thrombotic events before 35. So the question I get here, and I've gotten numerous times, are what if we don't have an AT3 diagnosis? And the vast majority of the time you won't. It's a very rare thing. It's, if patients are followed by hematology, you might, but otherwise you're likely going to see a handful at most, if not even less in your entire careers with a physical H&P documented diagnosis of a hereditary AT3 deficiency. But the take home here is there are components that lend you to believe we could be dealing with that. And that's something you keep in your mind is what are those things? What are the things that I look at that we might be dealing with? And it's I think more important to keep those in mind than it is to just rely upon a diagnosis. So Stephen's daughter, not shockingly here, medical history of a pulmonary embolism occurred during pregnancy. We'll kind of touch on why that's a heightened risk as well. One child, considering having another, it's probably going to be a very high risk pregnancy in that situation. Family history, like we talked about, father had a DVT. Up to 70% of pregnant women with this hereditary AT3 deficiency may experience thrombotic complications. Man, that's pretty impactful and almost makes you wonder, should we be testing AT3 levels as a standard lab, maybe in OB offices, when women present and they say, congratulations, you're pregnant, here's a lot of baseline labs we're going to test for you. I'm not a physician. I can't say yes or no to that, but I am saying that it's certainly an interesting thing with that level of risk. And some of the case studies that I'm happy to talk about if you guys are interested, that would weigh us down, and that'd be an hour itself of women that were pregnant and did end up needing thrombate therapy as well throughout their pregnancy. They're fascinating case studies. So again, perception, it's rare. We don't really need to test. The reality is that it's not as rare as most people believe. Now, we are perfusionists. We work in open heart surgery. We see it. We're not shocked. We see it. It's not super rare. It's not, certainly not super common, but it's there. It's prevalent enough to have something that we have to deal with. I was given a presentation at Ohio State a couple months ago. Excellent, brilliant anesthesiologist came up, had this wonderful conversation with him, but at the end of it, he ultimately said, I'm just not convinced that I need to test every cardiac surgical patient coming through with an AT3 level. The vast majority of them are going to be normal. Why are we spending the money on this? And again, most tests average between $200 and $300, so it's a drop in the bucket, but I digress. And I said, you're absolutely right. So why are we testing CBCs, CMPs, liver function, coags? Why are we testing any of that stuff before cardiac surgery? And you said, well, that's different. I see what you're getting at. That helps us guide and create a care plan for these patients pre-op, intra-op, and post-operatively. And I said, you're absolutely right. Why is AT3 different? And he just kind of paused there for a second and said, okay, I see what you're getting at. So the purpose there is, if we have that baseline AT3 level, we only have one opportunity to collect it. And that's the one opportunity. After surgery, there can be a number of factors that affect that AT3 level. You don't know if it's truly a baseline preoperatively or otherwise, but you have one opportunity to collect that. And honestly, whether it's an outpatient and you collect that in an office a few days before surgery, or whether it's an AM admit or a patient that's been in the hospital, it's important to at least have a launching pad to create our plan of care, how we're going to deal with the patient, and even post-operatively. AT3 levels don't matter to clinical management. He did not say that, but I have heard this before. So the risk for VTE is high, even if we don't identify hereditary deficiencies. So, it's, again, that 70% for women who are pregnant. We know that low AT3 levels can cause a poor response to heparin. I think, honestly, that's more than anything, that's the point of why we would want to know what your AT3 level is preoperatively. Now, the vast majority of the time, we give our dose of heparin. Patients have a reasonable, if not moderate, to a good response, especially if you have an HDR ahead of time with your HepCon and it says that patient has a slope of not 80, 90, 100 or above. You're confident. It's pretty accurate. It'll tell you that. I have also seen slopes before that are 90, 100, 110 with actual combined AT3 levels that were 60 and 50%. And I thought, oh, this is interesting. Why the difference between the two? I wonder which is going to be right. They had a fairly poor response. And that is almost every time. And that's primarily what I'm collecting data on right now, because I want to see which is a better predictor, an actual slope or an AT3 level. I can tell you I've collected about 20 or 30 patients so far. I want to do a few hundred before I kind of actually crunch any numbers on it. AT3 levels are way more accurate, at least in an anecdotal point right now. And I think it stands to reason that a lot of things can affect a sample. It's just a sample you're running in a HepCon versus a physical circulating level AT3. But again, soapbox, I'll stand down. Obstetrics, I'll kind of go over this quickly because obviously we aren't heavily involved in that, but certainly if you haven't seen one yet, you will at some point in your career have a pregnant woman either actively pregnant or postpartum period that needs some sort of cardiac surgery. I've seen two in my career so far, and they certainly shape the way you conduct yourself and the way you do things. We learn about pregnancy bypass, that sort of thing in school, but until you have to actively run one, work with anesthesia, work with your surgeon, it's certainly it's a nervous factor. There's no doubt, because now you're dealing with two lives that are on the table. It's very interesting. So thrombotic pulmonary embolism, is it getting the attention it deserves with this VT and obstetrics? Can't speak here. So the question we pose again is, are we adequately evaluating these VTE risks in these patients? I think it's a difficult thing because now we're dealing with a medical area of expertise that doesn't necessarily see a heavy amount of clotting disorders in the way that we would, at least in our side of things. So obviously there are a lot of changes that occur during pregnancy: venous distension, obviously increased volume, reduction in venous flow to lower extremities, and by the third trimester, a huge increase in clotting factors as well as decrease. With that kind of shifts, it stands to reason, especially if somebody has an undiagnosed hereditary deficiency, you're going to have problems. Now, this is an interesting one. When I was kind of first beginning to do these talks, I noticed the slide and I went to the resource and checked the paper and read this and all this. The first pregnancy case I ever had was a postpartum lady, was within a couple hours after delivering, who had a STEMI, was diagnosed. We had to rush to the operating room and do surgery, and she did have an extremely poor response to heparin. It was before we had a protocol. So essentially, with the poor response to heparin, the best we got was about 295, close to 300. So we administered thrombate to her. And it was kind of one of those, well, she just must have low AT3 levels, and we just left it at that. But this makes perfect sense that in that first period, even up to that 12 hours postpartum, there's a natural decrease in those AT3 levels that does return after a period of time. But I certainly experienced that case in point with that lady. She did have a good outcome, luckily. Obviously, risk of these, we can see here the 12 weeks postpartum, there's also still an increased risk for VTE over the non-partum reference levels here. I think it's just driving home the point here that there's increased risk in pregnancy. So these 70% of these pregnant women with hereditary AT don't really receive prophylactic therapy, and they can experience these complications. Again, I think it's a testament to potentially add this test in prepartum patients, I guess peripartum patients, that's the right word. And surrounding these prophylaxis of VTE can also have other issues like regional anesthesia for patients that undergo C-sections. Clotting disorders there can be a big deal as well. So is it getting the attention it deserves? Again, I don't think so. PEs account for nearly 10% of all deaths in hospitals. So more than anything, it's the most preventable cause, I think, if we can identify these things. Now, we can only do as much as we can do as perfusionists intraoperatively, which is the primary area that we work. But with more and more, and I'll say this word one time because I know it makes anyone I work with at Grifols take a deep breath in, primarily in the realm of ECMO, let's say that word, we see a lot of pulmonary embolism as well. So with these preventable causes, with more involvement in ECMO, we're in the unit more. We're watching these patients over periods of time more. We're watching the course of care. We're even being involved in it a lot of the time. And I encourage that as much as you possibly can. When I started at Wellstar Kennestone, I was actually the first ECMO coordinator. I helped to get the program off the ground and launch and all that stuff. So it's a passion of mine. It's kind of a side project passion of mine as well. And I think it's incredibly important to look at it from a holistic model. And maybe it's the nurse in me that likes to actually talk to people as opposed to machinery, but I like both. Again, it's, there's a risk in the general population as well. And you can kind of see the diversification here across the different disciplines and, these percentages of patients here. There's a risk in general population. We see it varies among surgical populations as well, but it's not without significant risk for all, especially in joint replacement surgery. But we'll talk about that in a second. In the case studies here. So Michael is 37. He's got a failing bicuspid aortic valve, advancing stenosis, mild LVH, and he does have a prior VTE event, which again is that light bulb when you read the H&P. Current complaint, little difficulty breathing, mild lower extremity swelling, work days, travel, we all know that. So he is a smoker, he has some alcohol consumption, doesn't want open heart surgery, he wants to discuss a TAVR. It's interesting, we are having younger and younger TAVR patients, but I digress. Hardened left calf, no DVT, color flow is decent on the Doppler. So we have a high platelet count, elevated TG, and elevated LDL, normal D-dimer, but we have an AT3 level of 71% of normal. Now, with this guy, I believe, in just a second we'll find out. This guy has a baseline ACT of 104, and of course he has a short PFA, which just leads to a heightened potential for clotting. This guy, I believe, does it say he does? Did I miss it? That might be the next patient. I think he has a diagnosis of AT3. Did I miss it? I guess I did. Never mind. That's in something else. So let's continue. Preoperatively, we administer 10,000 units. He does have a diagnosis of AT3 deficiency, sorry. So this guy is actually diagnosed ahead of time. Sorry, it's at the bottom there. I missed that underneath his profile there. So he does have known hereditary AT3 deficiency. So this is kind of showing how you would actually treat that otherwise. So we give 10,000 units of heparin and we give an actual dose, a calculated dose of AT. Now, would we give 343 units exactly in the field? No way. We are given the entire vial. Otherwise, you'll see pharmacists cringe everywhere. Is there necessarily a drawback to giving an entire vial if it's a couple hundred extra units? No. There are multiple studies that are done. There is not necessarily an indication for saying that it's not possible to overdose. Anything's possible to overdose, but I have read some case studies where people have gotten thousands upon thousands of units of thrombate, and there have not been any deleterious effects shown from that, but I digress. So uneventful anesthesia induction, good invasive monitoring for TEE. The TAVR was completed uneventfully. No intracardiac emboli or thrombi. Additional dose of AT post-op day 1. Why? So this is something I like to put in the back of everybody's minds as well. If you have a patient, and this is just a TAVR patient, but let's say it's a cardiac patient, you've identified they're heparin resistant. You've identified that they need thrombate. You give thrombate, whether it's pre-pump run, during the pump run, treat, reverse, send them out to the unit. Everything's great. So we've just sent them out to the unit, fully reversed protamine, back to their hypercoagulable state. Now they get to go sit in the unit. Best case scenario, 6 hours till extubation. That's best case. We all know it doesn't always happen that way. Maybe sitting up at 12 hours, standing, maybe 24 hours, maybe walking, getting out of the unit. That's all best case scenarios. If it doesn't, then it's prolonged in that much more. So they're very immobile and they're back to that hypercoagulable state. Is it any wonder these patients kind of weekly get shifted up to the floor because we need the beds, we need to turn them over, we need more room for surgery. They sit on the floor. Maybe the nurse is overloaded. She's got 7 or 8 patients. She doesn't have time to encourage him, and he says, I don't feel like walking right now, maybe later. And the nurse goes, I got stuff to do. I'm going to go do something else. And then all of a sudden, my calf really hurts, and it's hard and it's swollen. We got a DVT. That happens more frequently than you even know, because we don't have time to go up to the floor. We don't have time barely have time to even look at your patients postoperatively in the unit as perfusionists, but it does happen, and it does contribute to a lot of the AT3 issues. So again, back to the point here, additional dose post-op day 1, because he's identified as a hereditary deficient patient. So by giving an additional dose of AT post-op day 1, we allow the therapy that we're giving him to work. We allow that acceleration of the heparin binding until he can be transitioned onto an oral anticoagulant. So we keep that therapy going, and we prevent him from going back down to that hypercoagulable baseline. So discharge antiplatelet therapy, as you can imagine, aspirin, Plavix, 6 months, evaluated for additional anticoagulant therapy, 6 weeks post-op, fully recovered, returned to working and traveling. Follow up, obviously, with a hematologist and a surgeon. So he's probably going to be on multiple anticoagulants. Jessica's a little different. She's somebody we wouldn't normally see unless you maybe do cell savers for joint replacement surgeries and stuff like that. Severe DJD, crutches 6 months. She needs a bilateral hip replacement. Again, I wouldn't recommend doing 2 hips. I was an anesthesia tech for years. 2 hips at once is rough, but she's going to do it. Continuous spinal anesthesia. CBC is normal, good BMP, subarachnoid block. Right hip is done uneventfully, wound is closed. So we turn the patient for the left hip. She becomes a little agitated and short of breath, and the sats start to fall. Working diagnosis is maybe we got a pulmonary fat embolism. Not unreasonable. Certainly can happen in those deep joint and bone cases like that. Evaluations, platelet counts, PTINR, PTT, everything's normal, and elevated D-dimer, not shocking in these types of surgeries. TEG, we've got a max amplitude in a hypercoagulable state. Okay, it's a piece of information to think about. Our sats are falling more. So we've got some oxygen applied, low-dose IV heparin, but we're also doing a joint surgery here, so we got to balance it with not wanting the wound to hemorrhage. I can tell you, orthopedic surgeons, the few that I work with, they're not going to want to give heparin during their surgery, but that's a different story. You have to balance it against potentially a PE. So they give heparin, 2,500 units, nothing really happens. Give another 2,500, nothing happens, and another 2,500. So we got 7,500 on board now, and we really haven't moved. We barely moved with our ACT. We know as perfusionists, that's heparin resistance. We have a thought process of how we want to treat it, but they're in orthopedic surgery. It might not be something they see constantly. They might have a different thought process as to what's going on. So with the fingers becoming dusky, they're thinking, oh, do we have a hit patient here? So the failure of this ACT to respond to these 3 boluses, that's suspicion of potentially an alternative diagnosis. Somebody in the room had a light bulb go off, and they think, do we have a deficiency here? So they administer here after thinking maybe we got a hereditary deficiency. They give approximately 500 units. Again, they're given that entire vial, which I think it's anywhere from like 560 to 590 per vial, roughly depending on the process and how much they got in it. ACT rose to 280 seconds. And the take home there I like to point out as well is they didn't give additional heparin. That happens a lot, I think, in our pump runs because we're a little shell-shocked from, let's say you gave 40,000, you get a poor response, you give another 10, you give another 10, finally you give thrombate and you get a huge response. People always want to give more heparin with the thrombate dose they give. You just sometimes have to let the thrombate respond. Remember, it accelerates that response 1,000 times. So if you're giving something that has been missing and you already have a ton of circulating heparin, it will work. You got to trust the product. It's going to work. And if you give that additional heparin, then, I mean, it's not necessarily something that's going to be negative for the patient, but it's not necessary. You just have to let the product work sometimes. Hip body's negative, as you might imagine. AT3 level, and this is something during ICU monitoring. This is after the fact, after they gave a vial of AT3. AT3 level 65%. So clearly she was pretty deficient during the surgery as well. Oxygenation returns gradually, recovered uneventfully, good rehab. So obviously she's going to be on aspirin. She's going to be 6 months of a direct oral anticoagulant and reevaluated for lifetime. Referred for full evaluation, which revealed, shocking, drum roll, hereditary AT2 deficiency in consideration of a second oral anticoagulant agency. This is always interesting to me. Where's an ID bracelet that says she has AT deficiency? Now, I don't know if you're going to see anybody with an ID bracelet, but it stands to reason if you have an official diagnosis, maybe a card in your wallet or your purse might not be a terrible idea. In the event you do end up in an ER, maybe you have a STEMI or you need some sort of re-op, it would not be a terrible idea for people knowing going into it that you have this deficiency. But that's kind of all I have, unless you guys have any questions here.